And record. Welcome, everybody, to our monthly Care Coordination InfoShare Zoom session. Just a couple of things to know ahead of the session. If you have entered with a nickname or initials or any other name other than your full name, please rename yourself to your full name. We do compare that with our registration within the Care Coordinator InfoShare, which is in our SDS Training Academy. We use that to issue you a certificate of attendance worth an hour of CEH for today's live session. Um, if you have colleagues who couldn't make it to our session, um, or if you have to leave before half of it is over, uh, you need to go think about going in or suggest to go into our LMS, our training academy, and look at the recording and finish the short quiz, just a couple questions that we build based on the presentation. And that will earn you also a 1 hour certificate of attendance, CEH, for this session. We also require that you register within our academy for the series overall. So if you're not currently registered for that and you want to get credit, you'll need to register either which way. Either you get a certificate from today or you get it on another day by watching the recording. Either which way you have to register, or else it doesn't count. So just know that. Today we are recording our session, as you heard. Today we have some wonderful guest speakers and folks who are here to support us during Q&A. We have Sandra DeHart-Mayer, who is our Chief of Quality. And we also have our Jordan Grant, who is our manager with our policy unit. And our quality assurance staff, Meg Sampson and Esther Hayes, are here to support us for any Q&A as necessary. And the overall topic today is going to be key elements of quality assurance in regards to your work as a care coordinator. So we invite you to listen, form your questions. When it's time for Q&A, you can speak them, or you could raise your hand and we'll call on you, or you could chat them into the text area. So that being said, let's go ahead and get started. Um, by the way, if people have trouble hearing or seeing or something, sometimes it's counterintuitive, but if you leave the session and come back in, it helps. So you might want to go out and jump back in. All right, that's what I know. And go ahead. I'd like to invite Sandra DeHart-Mayer. Go ahead. Thank you.
Okay, can you guys see my screen?
Yes, and we can
All
hear
right.
you too.
Perfect. Thank goodness. All right, so I just have a quick overview of quality assurance here at SDS. And I'm going to touch on a couple things, and then at the end, I'll turn it over to Meg if there are any questions, because she's truly the expert on everything. So if you want to hold your questions till the end, that would be wonderful. And then Meg and I can work through them. But honestly, it'll probably be her. All right. So I want to start off, and I just want to apologize, because if you went to the AADD meeting a couple months ago, I did the same presentation. So deja vu for you. So CMS, requires that each state have a quality framework. And so to guide that work, CMS has created what are called assurances. And these assurances ensure that there's consistency and quality across all the states for Medicaid-funded home and community-based services. And I tried to put this in a way that kind of represents visually how it works, because it's a lot of information and it can be a little confusing. So we have CMS here, and then within CMS, we have the assurances. And then within those assurances, we have what are called sub-assurances. And those are the benchmarks that we need to meet in relation to the assurances. And then within that, there are the performance measures. And so SDS, through the guidance of a contractor years ago, created performance measures as the benchmarks for which we meet and measure compliance for that sub-assurance. And these are updated periodically. So Jordan can speak more to this later if you guys have questions, but we're in the process of updating some of them right now for next year. So we want to give you an example. So here's an assurance. From there, we can have multiple sub-assurances. And I won't read through all of these, but we can look at just one of them as an example. So again, the assurance is, the state demonstrates, sorry, let me point to this. It's this first one here on the very top. So demonstrates an ongoing, I'm sorry. I should put on my glasses. Yes. So the assurance is the state demonstrates it has designed and implemented an effective system for assuring waiver participants' health and welfare. So you'll see that assurance here. And then if we go over and look at the sub-assurance, that states that on an ongoing basis that we identify, address, and seek to prevent instances of abuse, neglect, exploitation, and unexplained death. And so we do that. We measure that through our performance measures. And one that I'm sure you're very familiar with that we can look at here today is this second one down, which is number and percent of providers that submitted central intake reports involving critical incidents within 1 business day. So we are consistently measuring this, and our benchmark is 86%. So anything 85 and below means we are not meeting that benchmark. And specifically to this one, we've actually noticed a dip lately, in particular to APDD waiver recipients. So QA has been reaching out to providers, to remind people about submitting CIRs on time, and also to be checking your dates. When you're submitting those, please check your dates as you're entering, because that seems to be the majority of the issues that we're seeing. And then it causes us to not be able to meet that benchmark. Okay, so keeping in mind all of those assurances, sub-assurances, performance measures, now we can kind of look at how that is monitored within SDS. So SDS has a quality improvement strategy, and it operates through a tiered committee structure. So first, we have the quality improvement task committees, and they're meeting on a regular set basis to review the performance measures, do deep dives into those that are not meeting the benchmarks. And then these committees are providing that information, summarizing and bringing it forth on a monthly basis to the quality improvement work group, which is chaired by myself and includes all committee chairs and the rest of SDS executive leadership. And in this meeting, each chair basically presents what's going on in their committee, reports out on the aggregated data, and then gives a proposal for any remediation plans for those performance measures that are not meeting that benchmark. And then lastly, on a quarterly basis, we take that information, the executive leadership team, and we bring that to the commissioner's office for the Quality Improvement Steering Committee. And that's chaired by Department of Health's Deputy Commissioner. And this committee, during this time, we look at the different strategies for implementation, review the reports, talk about remediation actions. And then if there's anything that needs to be done further, as far as resource allocation, we talk about that as well. And these groups all coordinate with external partners, and we all report on it up to the commissioner's office. So I just talked about a little bit about those task committees. Can you guys hear me, or is that somebody?
Yeah, somebody was muted. It's okay.
So SDS has 9 task committees. And again, these committees analyze waiver-specific data, identify performance deficiencies, and recommend corrective action plans. So anything below that 86% mark, they're talking about within these committees. They're talking about the good things too, but they're really focusing on those that are not meeting the benchmark, so that they can look at the root causes of what's going on and then bring that forward, to talk about remediation plans or quality improvement plans, whatever you'd like to call it. So here's our 9 different groups: financial accountability, health and welfare, IT, and this is our IT partners.
Go to the car. Yeah.
If you could go on mute, that'd be wonderful. Policy, mortality, qualified providers, long-term services, support plan, and level of care. And here at SDS, we follow a robust continuous quality improvement structure. So every month, our research unit, we have a whole research unit, they are gathering data, collecting from Harmony, and they're analyzing that data and putting it into a place where then the managers of those different task committees can go in and further analyze it and then report out on it to their task committees. And then they're planning if there needs to be any type of remediation plan, and then implementing that remediation plan. And then we start all over. So CQI is a continual process. We're continually looking at things and working to improve. And this is just a glimpse of some of the audits and reviews that occur. So SDS is constantly under an immense amount of scrutiny, by CMS, by the state of Alaska, through legislative audits. So there's a lot of people looking at our data all of the time to see how we're doing. So just some quick key takeaways. We are very committed to quality. As you can see, we have a very, very robust system here. We rely on stakeholder engagement. It's imperative so that we can continue to ensure that we're providing quality services to our recipients. And lastly, we're future focused. And so when I say that, I've only been in this position, I think 8 months, and I've had the opportunity to talk to lots of providers during that time. And so I just want to put it out there that I appreciate feedback, and I'm always open to it, so that we can continue with our CQI process and really work on continuing to look at how we can improve. Oops. And share. There we go. All right. I know that was a lot of information. I can throw it in a PDF and send it out. But are there any questions from Meg and I or Esther?
Thank you for that presentation. Folks, go ahead and either raise your hand or unmute and join in. If you're not speaking, if you could please mute. That'll help keep our line nice and clean. What are your questions?
Susie has her hand up.
Go ahead.
Thank you. I was wondering, so this sounds a lot like data coming in and evaluation of the data and meeting those thresholds. What happens when there's a report regarding an assisted living home and it really needs to be followed up on by the state of Alaska? Is this a different presentation that I need to be asking this question on?
Nope, this is it, and I'll defer to Meg.
When a CIR comes in, an incident report, it can go to APS, licensing, QA, or a combination of any of those entities. So if an incident report is reported that involves an assisted living home, then that is automatically screened to licensing for review also.
Okay, so APS isn't always informed. Then it would go to licensing first, and then they would decide.
No, it would, it actually, if it meets the threshold for APS and it meets the threshold for quality assurance and for licensing, it may go to all three entities. And then, depending upon, what the, allegations are, if it's an assisted, living home, generally licensing takes the lead on those.
Okay, so if I needed to follow up, I would on on a report regarding an assisted living home that's pretty consistently I am consistently reporting a specific home. I would follow up with licensing then.
That would be, I would say that would be the best place to start. Yes.
Okay, thank you.
There are a couple questions in the chat too. We can read those out.
I'm answering the first one on check your dates, but I wasn't typing
Okay.
quick enough.
That's okay.
So CIRs must be reported within 1 business day. And in looking at the ones that are not, it's been noted that it's just incorrect dates being input. And so I can let Meg, if there's anything else you want to say to that.
Yeah, so there's a couple of dates that are input when you complete the incident report. One of those is the date that the incident became known to the reporter. And that's a really important date to ensure that you're entering that correctly. And then the date of the incident is also input by the reporter. And so when we're, when our research and analysis team is pulling the data for our performance measure, they're looking specifically at the date the incident became known to the reporter, and then also the date that the report was submitted. We've actually had cases that we've noted where the date that the incident became known to the reporter actually occurred before the actual incident. So, we're assuming that that's just some type of, keying error there. So that's what we're asking, is if you could just double check those dates. And I know, when we switch to a new year, we definitely dip down, in January, because it's real easy, to put 2024 instead of 2025. So that really affected our performance measure then. So that's what we're asking. Does that explain what you were asking?
Yes, it does. Thank you.
Okay, great.
And I'll read these off to you, Meg. Has there been any work to have the CIR stay open longer?
I'm not sure exactly what's meant by that.
Hi, it's Jacqueline Culleton. I had asked the question. So when you're doing a CIR, it only allows you to enter the CIR for a couple minutes and then it will shut off. And you have to restart the process over again. And so I was wondering if there had been any work to have that report stay open longer without erroring out and having to restart it over and over again.
I do not know the answer to that. We can follow up and with WellSky and with our research and analysis and take a look at that.
Yeah, we definitely weren't aware of that. So if people are experiencing that, we need to look into it. I'll let our research team know.
That would be amazing. It's a huge barrier, not only for provider agencies, but also if a family tries to do it, because it only stays open for a couple minutes. And
Is
so
this?
if you
Oh, I'm
get
sorry.
a information for the CIR in, but then you have to enter the recipient information, it'll normally time you out and then you have to do it over.
I just want to ask, I see one thumbs up. Is this kind of across the board that people are seeing it? That just helps me to know, have a better idea of. Okay, I see a couple thumbs up. All right, well, thank you. We will definitely look into that. Next question, should we note in the narrative if we receive a report on Friday and are not entering the CIR until Monday?
What do you mean?
I
If you
only asked because that's, sorry, I was the one who asked the question. I only asked because that's the next business day. Is it helpful to you guys to have that somewhere in the narrative so you don't have to track weekends?
No, the system actually it's built into the algorithm or how research and analysis pulls that data. They exclude weekend days and state holidays. So if it's submitted, if you became aware of an incident on a Friday and the report is submitted on Monday, it will not be counted late.
Why am I in safe driving mode?
All right, any thoughts or talking about simplifying the online CIR?
It's been in discussion for some time.
That looks like just a note. Pairs with the phone number. Okay, I see lots of yeses. I see Sarah, you have your hand up.
Yes, ma'am. So I have a question for you just in regards to, I understand we're in a timeline, 24 hours is the ideal when an incident occurs, but we're also in this environment where if something doesn't feel right or seems off, we should also report. And in my experience, there's been times where there's not necessarily an incident that happens, but there might be some strange or concerning behavior by somebody on someone's team that might back up. So there might not be like an incident date that you become aware of something. Maybe you slowly start to see a pattern that seems strange. So in this scenario, like I have, given or submitted incident reports kind of outlining whatever the concerning issue is, but because of the nature of it just slowly becoming something that seems weird, by default, I'm already in violation of 24 hours.
So
how do-
So when we say a critical incident report, I can't remember if there's 8 or 9 that are outlined in regulations. And so we're specifically only looking at those 8 or 9 events. Those are actually, if you want to say, coded or marked behind the scenes by our screeners. And so when our research and analysis team pulls that, then we're specifically only looking at those reports that meet, like that there was an accident incident with medical intervention, a death, restrictive intervention, the medication errors, those types of things. We're specifically only looking at those. Does that help answer your question?
Yeah, it is helpful because I think I don't know. I don't know because I can't speak for other people, but I would imagine some people might be worried about filing a report about some kind of a weird situation because they might feel worried that they're outside of the guideline, right? So we don't want the criteria of the reporting to, you know, make people shy away from reporting itself, right? So that's
Right.
why I was asking, like, if something feels off, even if it's been something that slowly builds over time that it seems off, like it's probably a good idea to get it written down and, submitted. Thank you.
Yes.
Okay, there's a lot of questions. I'm trying to keep up here. So similar to that, if you receive a generic voicemail, like from a hospital, and then it takes 2 days to get more information on the incident, what date would you put in your CIR?
Well, the date that you became aware of it. We would request that if you receive information, like somebody was admitted to the hospital and you don't know the details, to just go ahead and submit that report and state that, this recipient was admitted to the hospital and you're waiting for details. And then when you get those details, then you can submit that to us.
And we have questions about findings on CIRs and care coordinators receiving those. I believe those are confidential.
Yes.
There were a couple questions on that. Needing longer template. Yep, I can go. Jennifer, I see your hand up.
Yeah, I have an individual who has a lot of behavior outbursts, and the provider agency tends to send me all that information for like 2 weeks worth all at once. And since the outbursts are all very similar, I've been lumping them all into one when I get them and reporting all at once. Is that acceptable, or do you need a different CIR for each incident? Because they're similar, I'm assuming it's fine. I was assuming that because if it was a different type of incident, like a hospitalization or something like that, then I would need to report that differently. What's your thoughts on that?
So what you're saying is you receive one phone call from a different provider agency, and you're on various incidents that have happened during the course of, say, like a week.
They will send me all of their CIRs all at once for 2 weeks, approximately sometimes a month. And so I'm getting all the details on it all at once. And so then, even though it's over a period of time, her behavior episodes are all very similar. So this date, this happened, this date, this happened, on and on and on throughout this period of time. So I'm paraphrasing them into one. But do they need to be broken out separately for data collection purposes?
So you received it all on one date. So the date
Correct.
you became known of these incidents is all the same.
Correct.
Esther, if you want to jump in, how have we been seeing those come in?
It also depends on what's an outburst, right? So
That's a good point.
the population we serve, of course, there's a big range. So unless there was harm to self or others, unless there was law enforcement involvement, unless there was some sort of restraint used, not all of that is a reportable incident. So if it feels like they're just really having a bad day or their meds need to be adjusted, if you're not sure, of course, fill out a critical incident report and we'll determine how to screen it and where it sits with regulation. But also we do see compilations, or you might summarize, I got this information and this is about a 2 or 3 week window of what I'm seeing. But it's when it becomes known to you, really is that date in question.
That works. Thank you.
You're welcome.
I am just trying to get through all of these here.
And folks, if we don't get to your question, because this is a really good discussion, we will get back to you on your answer, with an answer afterwards, because we still have Jordan to present on performance measures, and we want to make sure that she is heard and she has some time for questions. So why don't we allow 2 more minutes to put things in the chat, and then Sandra, we could give you the list of all the questions so that we could follow up with folks afterwards in a week or so, just if we don't get to everyone.
Yeah, no, I think I've gone through most of them, and a lot of them are things that we can answer offline, just more about Harmony updates. The The last one is the number open 24/7. You can leave a voicemail. There are not people answering 24/7, but our central intake, you can leave a voicemail and then they'll get back to you. There aren't any other questions. I'll turn it over to Jordan.
Hey everyone, my name is Jordan. Nice to see so many familiar faces on here. Sandra did an excellent job of explaining sort of how our quality framework works. And I was just going to talk a little bit about how performance measures are developed, what the timeline is on performance measures, how CMS looks at them, and sort of how the state interacts with CMS for that. So waivers are on a 5-year cycle. I'm not sure how common that knowledge is. We do put them out for public comment when they're up for renewal. So we are actually working on renewal for 4 of the waivers, everything but ISW right now, for a new cycle starting July 1st, 2026. So sometime this fall, we will be issuing an e-alert that says, hey, look, here's our draft. What do you think? And everyone will get a chance to take a look, give comments back. And all of the waivers, the draft waivers, have our performance measures listed right there. So you'll be able to actually see what the draft performance measures are. So we draft performance measures to meet these sub-assurances. We have the assurances that Sandra showed you, and then all of the assurances have sub-assurances that CMS likes us to demonstrate. I think demonstrate's probably the best word for this. So we come up, it's up to the states to come up with performance measures that fulfill and demonstrate each of those sub-assurances. So sometimes we look at things and we say, oh, you know, this performance measure, the way we measured it is a little wonky, or we don't have this data available. Sometimes what is available for Alaska or available for other states is a little bit different in Alaska. And one thing about the performance measures, kind of in the weeds for this, but take you back to math class, is they all are measured in a fraction because we're looking for a percent at the end. So you have the numerator and the denominator. And one thing about our performance measures is that CMS just doesn't like 0 denominators. So if an event didn't happen, CMS is like, why aren't you looking harder for it? And so we're going to be making a couple tweaks to some of our performance measures to reflect that change. But essentially what you'll see, and what we'd love feedback on, is to look at our performance measures when they come out for public comment, see, does this make sense? And sort of get a look behind the curtain. You get to see everything that's in the waiver drafts and comment on it. And then these performance measures are what we report to CMS annually in a report called 372. So we give that data to CMS, and it's really a dialogue between us and our federal partners to determine how are we doing, how is Alaska doing on all of these? And like Sandra mentioned, the benchmark is 86%. So if we are over 86% on these performance measures, we usually do pretty well. And if we are under, we have some explaining to do to CMS about what our remediation is. So that's kind of how the performance measures work. That's why in addition to health, safety, welfare, and the integrity of our programs, we do have to answer for these and make sure that we are staying above board and above benchmark. So happy to take any other questions. Sandra did a fantastic job of kind of explaining how that all works. But if there are other questions, I'm happy to answer here, or you can always shoot me an email and I'll try my best to get back to you.
I was just going to comment that we used to get updates on like how we're doing with our critical illness reports, how we're doing the timelines for our support plans, our renewals, that kind of thing. We used to do it by type of waiver that people were on and all of that. Lynn Kilman-Cruz used to come to monthly meetings and talk to us about that, maybe quarterly or something. Is that something that maybe Kat can do at our meetings quarterly or something that we have monthly like this?
Yeah, I think that's something we could definitely discuss and figure out what the best timeline for that is. But I do think it's really helpful for all of our stakeholders to sort of understand how performance measures work. And that, I think, of course, includes all of our care coordinators, because y'all are so important to how this whole machine operates. And so I do think that that's something we could definitely discuss. It's helpful to know sort of what what we're reporting to CMS and what that looks like. Performance measures, wow, and everyone, I know. If there's any other questions, feel free to pop them in the chat, or again, happy to answer them at a different time. I do see one in the chat. Is one of the performance measures pertaining to how waiver, fair hearing, and mediation? If so, what is the best course for a recipient provider CC who doesn't feel like a mediator is acting appropriately as a mediator? Since it will be outside of SDS, would that still be a CIR? Absolutely submit that as a CIR for the time being. We would be interested in that. And there is, I believe, if not a performance measure for it, we do have a section in the waivers. I think it is Appendix F that deals with fair hearing. So that is still something, even if it doesn't have a direct performance measure, it's still something that we look at and we care about. So please submit that as a CIR, and we will get that routed the best we can. And then I see another question. Is there any way for level of care renewal dates to be static rather than changing sometimes annually? It may help improve the numbers overall if there was a set date. So great question. For level of care, we are required to reestablish level of care no further than once every 12 months. So there are some limitations depending on when applications are received, availability of staffing levels. Sometimes weather is a factor, as many of you know, and level of care is typically just determined based on the assessment date. So because those things can change a little bit, they are subject to changing. We can't just set them to renew at a certain date. So unfortunately, there's always going to be a little bit of wiggle room there, but we do try to keep them fairly consistent if we can. I see a question about clients who may need a level of care letter when level of care is overdue. I'd love it if you could send that in an email. If you have any questions like that to training, we can get you routed to the right source to get that connected. Is that okay, Kara?
Yes.
I think many of you are familiar with training's email. So if level of care is expired in March and the new assessment was done in July, done in July with a new level of care, should we submit that as a CIR? Great question. I think email to Kara, and we can get you routed to our assessment team. That's probably the best course of action there. Of course, if you wanted to keep something for your own records, you're always welcome to submit something as a CIR. We'd rather have it. I think for everyone at SDS, we'd rather have anyone report the CIR than not report it. If there's a question, go ahead and submit it. There's no problem. Our teams are trained to take a look at what needs to go forward and where it needs to go to. So if ever a doubt, feel free to put it in a CIR and send it out to us. We're happy to receive it. All right, I see the chat slowed down. I can turn it back over to
Jordan. There's one more question in the chat from Sarah
I'm
about
sorry.
feedback on requirements to a waiver.
Oh my gosh, Sarah, yes, absolutely. There is feedback. Let me read the second part of your question. ALI waiver, ALHs don't provide escort or transport. Yes. So when we put the waivers out for public comment, you'll see an e-alert, and they will also be posted to our website, the draft waivers. There's a 30-day public comment period, and we will hold a hearing also. It's really, really helpful to us to hear things during this public comment period. It's especially helpful to hear them in writing, because what we do is we actually go through every single comment we receive about the waivers, and we look at how many we receive on it, how they fit into the overall waiver structure, what CMS's rules are, what our rules are, and we determine the path forward. So we really, really rely on your comments and your feedback. So absolutely, when you see things like that, I would wait until you see the drafts come out, and then you can look and see the drafts are like 300 pages long, because that's how long a waiver is. They're like 300 pages each, and we highlight the changed information in there so you can see exactly what changed. We usually lay it out also in a bullet form, like we changed this, we updated this, we updated this, why we updated this, and a little bit of rationale. But yes, absolutely, you can give feedback, and we would be thrilled. We'd be thrilled. Thank you so much. What am I missing here? Any other questions? Is there a different process when reporting on facilities like healthcare services? Lori, are you thinking facilities like a hospital or facilities like assisted living facility? Because assisted living facility is totally good to go through CIR. If it's like a hospital or other.
Yeah, I just remember there was a different process. I think one time I needed to report on a rehab center, and I just don't recall that process.
Yeah, they are a subset of residential licensing. I believe they're not part of that's assisted living licensing, but they are part of healthcare services. I would say if you're concerned, submit it as a CIR, and we can try to get it to the right place. And then I can follow up and make sure that we get you the right info for where to submit. Because there is a different team that handles facilities licensing. And Meg might know the answer to this. Meg or Esther might know.
I don't have the email address right offhand, but there is a different process. But when a report does come in through central intake and it gets routed to us, we do forward those on to the appropriate entities. So we would forward that on to healthcare facilities and licensing.
Thanks, Meg. Yeah.
Thank you.
Appreciate that. Great question, Lori. And then it looks like one about OCS. Is OCS reporting still separate? I've heard differing information from a variety of teams. Oh, Sandra, it looks like yes, OCS is separate. I defer to you, Sandra, if you want to take this one.
So the OCS process, they do have 24/7 intake, so you can call them. They also have an online and you can email. But they are separate. But like Meg said, for licensing, if we get something and we're like, oh, this is really an OCS report, we'll forward it on. But it's better for them if you could contact them directly, just because then they don't have to rewrite everything into their format from our format and all that fun stuff.
Can you maybe, and I see questions have slowed down, but can you maybe talk a little bit more about CIRs and why folks don't hear back? Because we do get questions with training a lot about, I submitted 15 CIRs and I never heard back. Nobody ever called me and I don't know what's going on. Can you maybe explain why that is? And that sometimes investigations do take a long time. There's different folks involved and maybe you won't always get a follow-up. But I just don't want people to think that just because they submit reports, they're not going anywhere because they're not hearing back. So.
Yeah, and so we have a couple of screeners that actually take a look at every single report that gets submitted to QA, and we get anywhere from 1,500 to 2,000 a month. So we get a lot. So it's not possible. We just don't have the manpower to respond to every single person who calls up and says, did you get that report that we submitted? There's no way that we'll have the manpower to do that. And then also those that get screened in for further investigation, that does take a little while to gather the information that we need. And what we're gathering is it's confidential information. And so we can't tell you, if it was about like something that happened with another provider, we can't tell you what the outcome of that is, if they were sanctioned, that's just not public information. So unfortunately, we can't share that with you. But if there are questions, we do reach out to the reporter. And a lot of times, when QA is asking for information from care coordinators, a lot of times it's just to, verify like what information that you guys have and when you had it and stuff like that. And it may be not anything to do. It's just to get additional, find out additional information about maybe what's going on in the recipient's, environment or home or whatever, so that we may be doing an entirely different investigation. So not all the time when you hear from QA it doesn't mean necessarily that you're under investigation, but just that we need some additional information. We need to take a look at the notes that you have regarding an individual. But unfortunately, like I said, the reports, if it involves a different agency, that's, considered confidential, and we cannot release that information. And I'm sure you probably, if it was your agency, you wouldn't want us to release that information to somebody else either.
I'm just going to say the hard part about that is the fact that we have to put in a plan of care all the details about these critical incident reports. And when staff put them in and then maybe they leave or they're no longer there, and then they tell us, well, we couldn't print it because we didn't know how on our computer or whatever, then we're kind of stuck as care coordinators trying to guess what kind of really might have happened in that situation. And the reason they're written is to help us kind of problem solve what could have been done different and all of that. So hearing it firsthand from the person who put it in there is super helpful. And sometimes we don't have that option. I've run into that many times.
Thanks for that information. Any other questions?
And if you think of a question afterwards, just send us an email. Write your question accordingly.
Lane put something in the chat.
I don't know the answer to that. I don't know if Meg does, but I can ask our research team.
I think I do. The one about the date of birth.
Go for
Is that
it. Well, you know
Okay.
everything. Yeah. That's
All right. No, but it was just because I helped develop the input on the teams that developed it and answered the question around that. So date of birth is just a unique identifier. So it's a way to, I'm going to say it clunky, right? But it's a way to have a unique identifier around that particular report. And I'm pretty sure it's not required, that it doesn't have one of those little red stars by it that makes you put it in. But it's just and if it does, the best answer I have is because it's a unique identifier. They don't store it or use it for anything, because of your age and whatever. It's just a unique date. And why it can't generate the person's age, underlying functionality of when you enter something once and attaching it to other pieces of information about a particular person in Harmony. Harmony is two phases. Phase 1 was CIR and all of its attendant processes, and phase 2 was the Harmony that we use as care coordinators. So those two do not talk to each other because because of the nature of the information and just the product itself. So those are my best answers. Thanks.
Okay, I don't think we have any more questions, Karen. And you're muted, Karen, so we can't hear you.
Sorry about that. So this has been a wonderful session. I really want to thank our presenters, Jordan and Sandra, Meg, Esther, all of our support staff here with training and care coordinator liaison. again, these are great questions. We have gathered them. We've given some guidance on what to do with these questions and the information that we've given out. We'll have this recording up on our YouTube channel tomorrow, and we'll send an email to you inviting you to go ahead and download your certificate within the SDS Training Academy. For those of us who were in our care coordinator community who are unable to attend, and if anybody asks you, just say, spread the word. It'll be available tomorrow, and people can have at it and engage in the recording and a couple of questions online in the Academy, and then get their certificate. I want to thank everybody for attending and giving us these wonderful, lively questions and all your thoughts, and especially for what you do to help our vulnerable Alaskans. We'll go ahead and close our session.